In this video, I'm going to be building on the previous video of first-line chemotherapy, where we established doublet chemotherapy as a preferred option and looking at triplet chemotherapy regimens and situations where this might be considered. We've been talking about after staging and categorizing patients into localized or locally advanced or stage 4 setting, or locally advanced unresectable, where surgery is not going to be the best approach. We've been talking about therapy approaches in this palliative setting. We talked about in the principles of chemotherapy the different classes of chemotherapy, namely fluoropyrimidines and examples of those, platinums, irinotecan, topoisomerase 1 inhibitors, and taxanes, and that combining these different agents can be synergistic. And we talked about a number of doublet chemotherapy regimens. In this video, we're going to be focusing on triplets and also allude to a quadruplet regimen combining all 4 of the active chemotherapies in this disease. This again is the overview of how one thinks about the treatment planning through the different lines of therapy after being diagnosed in this situation of stage 4 unresectable or recurrent after previous perioperative therapy. And in the previous video, we established FOLFOX as a preferred doublet chemotherapy regimen. But here we're going to be looking at triplet chemotherapy regimens and when one might consider that to be used. As a benchmark, we talked about what might be expected with doublet chemotherapy in terms of survival rates, and that really one of the main goals of using chemotherapy in this situation is with palliative intent, which means to improve symptoms of the cancer or delay the onset of those symptoms. And that really the name of the game is not only to improve survival length, but also to improve and maintain quality of life by trying to minimize side effects of that therapy. Again, we established FOLFOX as a preferred chemotherapy regimen, which is folinic acid, 5-FU, and oxaliplatin. One can exchange the 5-FU with the oral version of capecitabine in a regimen called Capox or Zelox, Xeloda being the trade name of capecitabine. And in some situations, FOLFIRI can be used as an alternative because it is a non-neurotoxic regimen compared to oxaliplatin. And that, generally speaking, the consensus is that oxaliplatin is preferred over cisplatin. The benchmark outcomes of one might anticipate are listed here with response rates, disease control rates, and the median progression-free survival and overall survival. But what about triplet chemotherapy? Does it play a role here in this first-line setting? Well, what we see here is plotted on the x-axis the median overall survival in months, and looking and contrasting a number of different chemotherapy regimens. In green, doublet chemotherapy regimens, you can see FOLFOX here at the bottom, and in orange, the triplet chemotherapy regimens, some of which we've already discussed with epirubicin-based regimens. And in the REAL-2 study, which looked at different versions of epirubicin-based triplet regimens, starting with the parent ECF and comparing to different combinations of cisplatin and 5-FU or capecitabine and oxaliplatin. And really from this study, we learned that from an efficacy standpoint, cisplatin and oxaliplatin can be considered interchangeable, and 5-FU and capecitabine can be considered interchangeable. But that when we look at the side effect profiles, that really oxaliplatin becomes a preferred regimen. It's better tolerated, but does have a trade-off of a higher side effect profile of peripheral neuropathy. Remember, that is numbness and tingling in the fingertips or toes, cold sensitivity, and to the point where if it's used a lot with many doses can lead to significant problems with loss of sensation in the feet, leading to a balance disturbance and falls, tripping, and also dropping things with your hands. And so there's always a trade-off, and so we have to keep that in mind. We also looked at a different study that looked at irinotecan in the first-line setting, looking at FOLFIRI in the first-line setting and transitioning to second-line platinum and capecitabine versus a more standard approach of a platinum and fluoropyrimidine, then FOLFIRI in second-line. And from this study, we learned that the outcomes were similar and that FOLFIRI could be used as a substitute in first line. In later videos, we're going to get to why still FOLFOX is preferred in first line, but there are some situations that we alluded to where FOLFIRI might be a preferred regimen in first line, like in a patient who has baseline neuropathy for other reasons, and we want to avoid further neurotoxicity, so we would avoid a platinum agent, for example, and FOLFIRI might be a good choice there. We did also talk about how epirubicin, although it had a role at one point, particularly in the perioperative setting, but was also a standard first-line regimen, really has fallen out of favor and an obsolete regimen, and that really isn't used in either the perioperative setting or in the metastatic setting. But what about other triplet regimens? The first one that was studied and some time ago was in a study called the V325 study, a phase 3 study looking at cisplatin 5-FU compared to docetaxel cisplatin 5-FU. And what we can see here is that there was an improvement in outcomes in terms of progression-free survival and overall survival, albeit modest. But this came with a trade-off of higher toxicity profile. So this is the general understanding, is that when you add a third chemotherapy drug, you may have improvement in outcomes to some degree, but it comes with a higher toxicity profile, including higher rates of low blood counts, or cytopenia as we call them, which can lead to risks of infection, also fatigue, higher rates of diarrhea and nausea and vomiting, and also importantly, especially when you're adding a taxane and a platinum together, both of which are neurotoxic, can lead to higher rates of neurotoxicity. So this became a discussion: is this marginal improvement in outcomes, response rate, progression-free survival, and overall survival warranted with the added side effect profile that comes with it? And the general consensus at the time when the study was published, and has carried through even to date, is it worth it? And the general consensus for most patients has been no, especially as we'll talk about, using these agents in tandem with doublet and monotherapy regimens can achieve the same goals, but at the same time limiting side effects along the way. An important study that was done, it was a randomized phase 2 study, was looking at what if we modify the doses in DCF, or modified DCF, and compare that to the parent DCF. You can see that the parent DCF has higher doses of each of the components, docetaxel, cisplatin, and 5-FU, over 5 days of a continuous infusion pump, compared to lower doses, almost half the dose of docetaxel, cisplatin, and while the 5-FU dose is a little bit higher, it's only over 2 days. And so a 2-week dosing schedule of modified DCF versus every 3-week dosing of the parent DCF. And the question was, is this as effective, but maybe better tolerated? And the answer was, it was actually looking to be trending to be better in terms of outcomes for PFS and OS, and also response rate, but also better tolerated. And so one might ask, how can that be with lower doses? Probably the answer is that patients were able to stay on the regimen longer because it was better tolerated, and so led to overall better outcomes. And that's shown here in terms of the side effect profile with the modified DCF compared to the parent DCF, where the side effect profile was all higher with the higher doses of chemo. And so this again speaks to the fact that dose modifications of therapies can make things better tolerated and allow you to stay on the therapy longer, and counterintuitively have them work better. But really, with the introduction of FLOT chemotherapy, again, because oxaliplatin is preferred over cisplatin, otherwise using the same agents, FLOT seems to be a little bit more preferred in most practices compared to DCF. And you can see here in this original study now, 15 years ago, a single-arm phase 2 study in the stage 4 newly diagnosed setting. And what we see here, that the median progression-free survival and overall survival were not that much better than one might expect with doublet chemotherapy, but this isn't a randomized study to compare. But response rates seem to be a little bit higher than one might expect. Remember, FOLFOX response rates would be in the order of 40 to 50%. And so that said, this is a relatively small sample set of only 52 patients. And we learned in the principles of clinical trials and when we talked about statistics that there could be random variation, especially with small numbers. In a follow-up study called the FLOT3 study, one of the groups in a non-randomized fashion received FLOT, and it was 127 patients, so a little bit larger. And again, the median survival and progression-free survival were in line with one might expect, even with doublet therapy, and the response rates weren't any different than one might expect with FOLFOX alone. So again, this is in a non-randomized study. My impression would be that in a randomized study of, say, FLOT versus FOLFOX, the addition of docetaxel would lead to marginal improvements in overall response rate, median survivals, and progression-free survivals, but it would be with the added toxicity profile of adding the docetaxel, specifically and importantly, an added risk of neuropathy, but also all the other things like fatigue, nausea, vomiting, diarrhea, and low blood counts. And so a third regimen is FOLFIRINOX, which is 5-FU, folinic acid, and irinotecan instead of the docetaxel, and then oxaliplatin. And this regimen is a common regimen in pancreatic cancer, and it was studied here in this single-arm, non-randomized phase 2 study of 41 patients. And again, the median progression-free survival and the median overall survivals were slightly higher than one might expect, again, non-randomized, and a response rate that was also impressive of 61%. And so again, the trade-off here of these marginal improvements is a little bit higher side effect profile. One thing to note is that this parent FOLFIRINOX regimen uses a 5-FU bolus. We talked about the bolus even with doublet therapy, and that in my practice, we don't include that. And certainly if it is included, it's the first thing to be dropped if there's any side effects. And so FOLFIRINOX, generally speaking, in most practices, is not used with the bolus, but this study did use that. So keep that in mind when we look now at the toxicity profile, and that generally speaking, FOLFIRINOX is more side effect profile than FOLFOX. And that said, compared to FLOT, it will have a lower neuropathy profile because it's only got one neurotoxic agent, oxaliplatin, whereas irinotecan does not cause neuropathy compared to, say, docetaxel. So this would be an advantage of FOLFIRINOX over FLOT in this setting. So general lower neuropathy compared to FLOT. So here we then have, in contrast, the three potential options of triplet regimens in that first line setting with DCF, whether it's modified or not, with FLOT, and with FOLFIRINOX. And it's always tricky comparing small non-randomized studies against each other. But in general, my impression would be that you will see, in compared to a doublet regimen, slightly higher response rate of about 5 to 10% higher, a slightly higher progression-free survival of maybe a month or so, and similarly with median overall survival, maybe a month longer. And so the real question, though, is the trade-off of adding a third drug to the doublet regimen, of having slightly higher outcomes, but with a higher toxicity profile, warranted? And again, the consensus has been over the years and continues to date that it's not worth it, and a doublet is preferred in the first line setting, and reserving some of these other agents, taxane or irinotecan, to be used in tandem in later lines to achieve the same overall survival ultimately, but with less side effect profile along the way. But there may be some circumstances where a triplet regimen could be considered, and I'll get to that in the next slide. In my opinion now, if I'm going to be using a 3-drug regimen in the first line setting, I prefer FOLFIRINOX because it really limits the amount of neuropathy compared to the regimens like FLOT and DCF, which have 2 neurotoxic agents, a platinum and a taxane. So why or when would we consider using a 3-drug regimen versus a 2-drug regimen? You can see there may be some situations where the patient has a really high disease burden, They have a lot of cancer sites and spots. They're having a lot of symptoms from their cancer. It's got a lot of pain, say, for example, bone lesions that can be painful, or a lot of liver disease that is causing right upper quadrant pain, or a lot of ascites fluid or effusions in the pleural cavity that are symptomatic. Then a response may be really desired, and we know that we can achieve a higher response rate. More patients will have experienced response if we add a third drug to the two-drug regimen. And so this might be a consideration to be done. Certainly, the situation on the other extreme, in the setting where you have minimal disease, only one or so sites of spread and not a lot of symptoms, but your intentions of therapy now are to be a little bit more aggressive, maybe to be amenable to surgery at some point, or chemoradiation to consolidate, to really try and optimize outcomes. In any of these situations, it might be worth the trade-off of a higher side effect profile. And we'll get to the oligometastatic discussion in a separate video. But really, the intention of using a triplet regimen has become standard in the curative intent setting, again, which we'll have a separate video on, where we're trying to optimize outcomes around the time of surgery by eliminating micrometastatic disease. And there it's considered warranted and worth the added risk of getting side effects, because now our goals of care are different. So again, really, we have to put into context the additional benefit that might be gained by adding a third drug with the trade-off of having more side effects. And you can see here again that adding oxaliplatin and docetaxel together, two neurotoxic drugs, will significantly increase the risk of neuropathy. Certainly with any triplet regimen, there'll be higher risks of low blood counts and other side effects like fatigue, etc., and infection as a consequence of the low blood counts. And then diarrhea for any of these triplet regimens, and particularly FOLFIRINOX with Irinotecan, that has a known side effect that has a high risk of diarrhea. So in general, outside of these situations, for stage 4 patients, the majority of patients, aside from maybe getting a higher response rate, the survival benefits are likely to be less pronounced when you use each of the drugs that would have been used in a triplet regimen in tandem later on as monotherapies or doublet therapies, can achieve the same outcome. I'm going to transition now to just talk about pharmacogenomic dosing of irinotecan. Now, we alluded to this in the principles of chemotherapy, that irinotecan is metabolized by an enzyme called UGT1A1. So in the population, we have different versions of this enzyme, and the differences occur in the promoter region. Remember, the promoter region is the region right at the front of the gene that turns the gene on and off through transcription. And so there are different versions of that promoter region. And in the human population, there are normal versions that are referred to as wild type that have a certain rate of transcription and a certain rate of activity of the enzyme. There are other versions that have differences in the promoter region that lead to lower transcription. So there's less of the enzyme around. And one of the common versions has 7 repeats of this base TATA compared to 6 repeats. And that version is called the star 28 allele. So in the human population, about half of the people have 2 copies of the normal version. And so they have a normal amount of this UGT1A1 enzyme. On the other hand, about 40% of the patients have 1 normal copy, but 1 refer to it as an abnormal copy or a less effective version of the enzyme. And about 10% of the human population has 2 copies of this abnormal version. And that's referred to as Gilbert's syndrome. Gilbert's syndrome is renowned to have higher baseline bilirubin levels because it's not metabolizing as quickly in the liver. And patients that have this 7-7 version have a higher risk of getting really low blood counts when given irinotecan because they have lower amounts of this enzyme around that are metabolizing irinotecan's active metabolite, SN38. And so the takeaway of this is that about 1 in 10 of people in the population, when given irinotecan, will be extremely sensitive and have higher rates of side effects like low blood counts, and as a consequence, infection, higher rates of fatigue, higher rates of diarrhea. And so, in general, it's important to note that in GI cancers, the standard dosing of irinotecan is 180 milligrams per meter squared. But with this recognition long ago, it was included in the black box warning of prescribing this drug, which the generic name is irinotecan, but the trade name is Camtazar, is that one would consider a dose reduction initially of this irinotecan drug for patients that are in this high risk 7-7 group. That said, even with this black box warning, it's not really standard to check for UGT1A1 genotyping, and it's not routinely dose modified. So everyone gets 180 milligrams per meter squared, and 1 in 10 patients can have really significant side effects with this drug. So with this high risk group, our group and others have looked at whether or not we can genotype dose irinotecan based on whatever the patient's genotype is by checking it before starting therapy. And with the concept being that patients that had 2 normal copies of the enzyme, who are considered normal or extensive metabolizers of drugs like irinotecan, could get a normal dose. Yet patients who have a copy of a normal allele, but also a copy of a high-risk allele, might be considered an intermediate metabolizer. And patients who have 2 high-risk alleles would be considered poor metabolizers. And with that understanding, when the original phase 1 studies were being performed to see what was a good tolerable dose of irinotecan, this really wasn't being taken into account. And so some patients were having a lot of side effects, potentially because of their genotype, that limited the dose level of what could have been achieved in the normal metabolizers. And so studies like this one performed escalation of irinotecan in the groups of patients who had these normal metabolizing enzymes. And in fact, the optimal dose was much, much higher than the standard dose of 180 milligrams. They were able to tolerate 310 milligrams per meter squared in the 6-6 group, and in the 6-7 group, 260 milligrams, still higher than 180. And so this concept was expanded on by looking at triplet regimens, now relevant to this discussion here today, is that because triplet regimens tend to have a higher side effect profile, one question was, what if we genotype dose the irinotecan? Can we make these triplet regimens a little bit more tolerable for each individual subgroup? And so the study that was performed looked at giving the patients that had the normal copies of the enzymes the regular dose of 180 milligrams, but patients who had an intermediate metabolizing, so 1 copy that's normal, 1 copy high risk, a slightly lower dose, and then patients who had 2 copies of the high risk allele, half the dose. And can we make this triplet regimen better tolerated for everybody? And the answer was, in this non-randomized study, yes, for both the addition of oxaliplatin with the irinotecan and 5-FU, or FOLFIRINOX, genotype-dosed irinotecan, and also with a taxane instead of oxaliplatin, in this case, nab-paclitaxel or Abraxane. So that leads us to looking at a quadruplet regimen, which we looked at in this I-FLOAT study. And although all 4 of these agents are considered standard agents across a number of cancer types, this was the first time that they were all combined together, hence why it was called a phase 1 study. And you can think of it as a merging of the FLOT regimen and the FOLFIRINOX regimen, because it has all the components of each of these regimens. And not to belabor the point, but this was the study looking at essentially 3 individual phase 1 studies. 1 phase 1 study for the patients who had normal copies of the enzyme, 1 phase 1 study for patients who had 1 normal copy and 1 high-risk copy, and then 1 phase 1 study for patients who had 2 high-risk copies. And you can see that the starting doses of irinotecan were different based on the genotype category, because it was expected that the patients who had 2 versions of the enzyme that weren't as effective, that they would be at higher risk of side effects. So we started at a quarter of the dose of a standard dose of irinotecan at 45 milligrams per meter squared. And in the most recent data set, 27 patients have been enrolled. Patients were eligible if they had stage 4 disease or unresectable disease, and you can see the breakdown of those two categories. And any upper GI cancer or tumor was eligible. You can see the majority were gastroesophageal adenocarcinomas. And again, the intention of this study was to escalate the dose as tolerable to find a safe and effective dose for each of these three genotype groups. And you can see the numbers of patients enrolled into each group and the current dose levels of each of the group as listed here. So the low and intermediate groups are both at 150 milligrams per meter squared and still accruing, and the high risk group is still at 45. And from this table down below, you can see the rules with which one would be able to escalate to the next dose if there was a certain number of patients treated at a certain dose and not having dose limiting toxicities. Then you could escalate up to the next cohort. And we talked about phase 1 studies and how they're conducted in the Principles of Clinical Trials video. And at the moment, you can see that some patients have experienced dose-limiting toxicity, mostly low blood counts, diarrhea, neutropenic fevers, and things like this that are expected with 3 and 4 drug regimens. But as long as they were limited and not common, we could dose escalate. So really the intention of this study was to see if we can improve on outcomes from triplet regimens. And in this initial look with a small sample set, we can see that response rates are really high with this quadruplet regimen. Specifically in this waterfall plot, you can see the different cancer types, but looking specifically at gastroesophageal cancer with a response rate of over 90%. Is really promising. And we talked about in the liquid biopsy video, patients that have a pre and post therapy ctDNA decline, amount of ctDNA in the blood usually bodes well. And you can see all the patients that were evaluable with ctDNA had declines in their ctDNA values. So again, very promising. So the real intention for this was a phase 1 study to find a tolerable dose of the irinotecan based on genotype dosing for each of the three categories, the low risk, intermediate risk, and high risk groups. And from that, move to larger studies in different situations, particularly in patients that are high risk in the perioperative setting. So can we do better than, say, FLOT in that setting? But also in the stage 4 setting, particularly in patients who are oligometastatic, and we'll talk about that in a separate video, where we're trying to be more aggressive to try to get to surgery with curative intent. And if that's the case, then why not be as aggressive as we can be with the most aggressive regimen if we can find a safe and tolerable dose? So this is the plan and an ongoing study. So summarizing what we've discussed, in the previous video, we established that a doublet chemotherapy regimen had better outcomes compared to best supportive care and was generally well tolerated with a known side effect profile. Here we've established that an additional drug or a triplet regimen can expand on that a little bit further, marginally, but comes with a higher side effect profile. And now I've introduced, what about if we add 4 together? Could we gain even more ground in terms of improvement in survival and other clinical endpoints, but not increasing the side effect profile significantly? And ultimately, the real question in the stage 4 setting as to whether or not to use a doublet or a triplet regimen is really after discussion with the patients of the potential benefits and the potential risks and personalizing the plan to their individual goals. Remember, we're always trying to balance in this stage 4 setting where it's generally accepted that more chemotherapy is not going to eradicate the cancer, whether or not a higher response rate or a marginally improved progression-free survival and marginally improved overall survival is worth the added side effect profile. And again, this has to be tailored to any individual patient. We've been talking about how chemotherapy is effective in all groups, whether you have certain biomarkers or not. And of course, we're going to be getting to videos on specific targeted immunotherapies for specific subgroups that have the appropriate biomarker. But we could be talking about doublet versus triplet therapy for any of them, but in particular for those patients that don't have an alternative targeted therapy or immunotherapy to add to the doublet therapy. in the end, it really is a personalized approach for adding a triplet therapy on top of a doublet. I mentioned a few situations that one would consider that in the stage 4 setting, and that includes patients who really have a lot of cancer-related symptoms, high burden of cancer, and we're really trying to obtain a response. And in those situations, one might consider using a triplet. And similarly, in the setting of having oligometastatic disease, where we're on the other extreme, don't have a lot of cancer, but we are intending to be a little bit more aggressive with the intention of moving on to more aggressive therapy with either radiation and or surgery. So overall, again, we've been talking about this first line setting where generally it's accepted to use a doublet chemotherapy, preferred as FOLFOX, but we've talked about situations where a triplet therapy could be introduced in certain situations. In the following videos, we're going to be talking about the biomarker subgroups, HER2, PD-L1, and Claudin, and also emerging biomarkers where a specific targeted therapy or immunotherapy can be added to the backbone chemotherapy, whether it be a doublet as preferred or a triplet chemotherapy regimen in certain situations. So in this video, I expanded on the establishment of a doublet therapy regimen in the first line setting and introduced a number of triplet chemotherapy regimens, namely DCF or FOLFIRINOX or FLOT, and certain situations that one might consider using them. And in the following videos, we're going to be looking at biomarker-based therapy superimposed on top of these chemotherapy regimens. So stay tuned for that. Thanks.